First Congregational Church in Cromwell, and just here to welcome those from Middlesex Hospital who are with us, and we're going back and recording the first session that we had because we had a snowstorm, and so Susan Daniels has been kind enough to come out and record this for us, and so tonight they're going to be sharing with us, Know Us Before You Need Us, and we will look forward to what she has to say. So without further ado, I'm going to introduce her.
Thank you. Well, thank you all for being here. I really appreciate the fact that you have an interest in hospice and palliative care because it's not something that's really well understood. My name is Susan Daniels. I'm the Hospice Resource Nurse Coordinator at Middlesex Health, and in that role I wear a variety of hats, but mainly what I do is communicate to people in the community about hospice and palliative care, which is something that a lot of people have just a vague notion of what it is, but they're afraid to hear more about it. So we always say we want you to know us before you need us, and that way when the time is right, you're not going to be under pressure in a stressful situation when you have to make decisions about whether or not you would like to have our services. I work in the home care department in Middlesex Health, and I'll be talking a little bit more about that as well. Our objectives today are that I would like to define what palliative care and hospice are for you, address some of the myths that people have about hospice care, and identify when and how to ask for a consultation. And when I say a consultation, I mean we either telephone consultation or we visit you in your home to talk to you about what your needs are and see if you can benefit from any of our services. So everybody wants to go to heaven, but nobody really wants to die, and that is the conundrum of modern medicine. We want you to know what could be in your future, hopefully the distant future, so that when the time is right to talk about hospice care, you'll be fully prepared and be able to seek out health care benefits for you or for someone whom you love. And I just want to say that palliative care is something that is available to people anytime you have a serious illness. And so you may know somebody right now who could benefit from our services, so I hope that pricks your ears up a little bit. So what is palliative care? I know that this graphic may be a little bit difficult to read, but basically it's demonstrating that palliative care and hospice care are patient-centered care, meaning that it's not just the patient that's at the center of care, it's the patient, their family, anybody whose lives are affected by the patient's serious illness. So if you can't read what's in the little bubbles that surround patient and family there at the center, we have volunteers on our services, physicians, and advanced practice registered nurses. We have spiritual counselors. We have social workers. We have a bereavement coordinator, home health aides, therapists, nurses, of course, and did I mention volunteers? We also are heavily invested in the volunteer aspect of our organization. Palliative care and palliative care is, think of it as an umbrella that will keep you safe at times of serious illness. So if you have a serious illness, whether or not your goal is to be cured for that illness or to just have your symptoms alleviated or somewhere in between. Maybe you're looking for life-extending treatment even though you can't hope for a cure. Regardless of what your goals of care are, if your serious illness impacts the quality of your life in any of the 8 domains of palliative care, then you may be able to benefit from our services. So the 8 domains of palliative care, which were established in 2004 by the National Consensus Project. It's a national organization of palliative care professionals that came together and said, what are the things that, let's try to standardize what palliative care means. What are the things that palliative care should include? It needs, if you have a good palliative care program, they've got a formal structure. That means that they have people who are in charge. It's a separate department within your healthcare organization, and hopefully it spans the whole continuum of care. And I'm very proud to say that Middlesex Health does do that. Palliative care should address certainly your physical needs. That's what most people, I think of when they think of palliative care, because small p palliative means symptom management, right? It means symptom abatement. So people think about the physical aspects of palliative care, and a lot of times that's how people come to use our services. So we ask people if they're having any pain, shortness of breath, nausea, even things like itch or fatigue, loss of appetite, all those kind of things your palliative care specialist can help with. Psychologically, we also address people, so we ask them, are you having any sadness, nervousness? Do you feel blue sometimes, and do you associate it with your illness? And if so, then we have professionals on our team who can address those specific needs. We address the social aspects of care, because when you think about it, any time somebody in the family has a serious illness, it's not just going to affect that person, it's going to affect the people who that person depends on, and also the people who depend on that person. So, and when I say family, I'm using that term very loosely. It could be anybody who's your social support system. So, in palliative care, we also make sure that you're, taking advantage of all the social programs that may be available to you in the community. Spiritual care is something that I think sometimes gets short shrift in medicine, and so palliative care also really tries to address that as well. Certainly, it's the religious aspect, what your cultural or religious beliefs are, that we address, but also just the existential pain that people have when they're experiencing a serious illness. I had a conversation with a gentleman just today who said to me when I, got to the part about asking him if he had any psychological symptoms. I said, do you have any sadness or anything? He said, I feel very frustrated and sad that I'm not the person I used to be. I feel like I'm losing who I was. And that sense of loss of identity is really what the spiritual aspects of palliative care can address as well. And it's something that, like I said, not usually when you walk into the doctor's office, you don't expect to have an existential discussion with your doctor necessarily, but why not? Because your illness can really be kind of governing the rest of your life and really starting to make you challenge some of the things that you always believed about yourself. Likewise with cultural, addressing the cultural aspects, we take courses and things like that. It's just so that we can understand that not everybody has the same goal of care. And even like within a family unit, you might have a husband and wife who have very different ideas about what illness should look like, how it should progress, how you should deal with things like that. Some people come from a belief that you should not complain, and other people are very feel like everybody needs to know if you have illness, and that's just one example of how even within the same family unit there might be cultural differences and how we experience pain and serious illness. So the palliative team is there to help with that. And then the one area where people get confused a lot about hospice and think that hospice is the same thing as palliative care is that one aspect of palliative care is care of the imminently dying, and that would be the hospice program. So if you think again of the palliative being like an umbrella that shelters you throughout your serious illness, one spoke under that umbrella is hospice care, but it's not a foregone conclusion that you'll even have to take advantage of that particular domain of palliative care. Or if you do, maybe it's down the road, and by having palliative care earlier on in your illness, you'll be ready when the time comes to elect hospice care. And then finally, we also deal with the ethical and legal aspects of serious illness in the healthcare industry. So we're advocates for you. We're advocates for you. If you feel like you're being pressured to accept one course of treatment, or if you feel that people aren't listening to your needs, and we view things through an ethical lens and a legal lens, of course, as well. So, as I said, I'm very proud that Middlesex Health offers the full gamut of palliative care. Here's what we offer in our community. First of all, we offer consultative services by phone. That's sometimes how people get their entry into palliative care. And usually that's done by me or another nurse. We get the referrals from a lot of different ways, but one of the most common ways that we get a palliative referral is that somebody goes on the internet and sees that we have a palliative program and calls us up and says, "What's this all about?" So the consultative services by phone, we ask you some standard questions based on those 8 domains of palliative care. Sometimes, it gets a little uncomfortable for people at times, and that's okay. I try to preface anything that people, might be nervous about answering by assuring them that if, you can have any answer or no answer is fine, but we just want to get the conversation going. And, I ask them about their physical symptoms, their psychological symptoms. I ask them a really important question. I ask them about their physical function, how they're doing around the house, because if you know someone with a serious illness, you'll know that over time you might see a decline in physical function. And as palliative experts, we're kind of trained to look at that in terms of what your illness trajectory is and what your needs might be. And then I ask them a question that if you were here previous weeks, you might have heard me talk about, but I say, what if your doctor had to make a decision right now about how he should take care of you? Would you want him to do everything that he can to extend your life more, even if it might mean more pain or discomfort? Or would you want him to focus on your symptoms, even if you might not live as long? Usually after I ask that question, I have a long silence, and you can kind of almost hear things percolating for the person on the other end of the telephone. And sometimes they have an answer for me. Sometimes they have an answer right away. Sometimes they have a qualified answer, and sometimes they say, they kind of talk it through, or they just say, what, I'm going to have to think about that more and get back to you on that. And any of those answers are good. The point is that it really gets people to start to think about palliative care, or to think about their goals of care, what they want to get out of healthcare treatment. Rather than just waiting for the doctor or the advanced practice registered nurse to say, well, this is what I think you should do, or this is what most people do, so this is what I'm going to recommend. You are at the center of patient-centered care, or the patient is at the center of patient-centered care, and their family, and so you should really be driving what kind of treatments we're offering. We should be offering you all the treatments that are available to you, or letting you know what would happen if you took no treatments at all as well. So it really kind of turns the whole conversation around so that you're really thinking about this illness in terms of your life and what you want, and how you can make the most of your life in spite of this illness. So we have that's the consultative services by phone. Then we have our palliative clinic. So sometimes after we have this consultative service, I'll say, if somebody's mobile and can get to a clinic, I'll make a recommendation that they meet with either our Director of Palliative Care Services, Dr. Anju Phillips, or Christopher Yee, our palliative APRN. They each do office hours once a week, and they meet with people there. They can talk about your physical needs, your social needs, prescribe medications for you if you need to. They do that in conjunction with your doctor who referred you. We do seek the referral from your physician before you go to the palliative clinic. They can talk to you. They have time to talk. I don't know how many of you have been to a doctor's appointment lately. Let's put telemedicine aside. Anytime that you go to see a doctor face-to-face, they generally have you booked for a certain period of time, and they have to do all their business within that 15 or 30-minute period of time. Usually it's 15 or 30 minutes blocks that they have to meet with you. So they're talking to you about all of those domains of care, but really what they're going to probably end up focusing on is your general doctor is going to be focusing on the problem at hand, what brought you to the doctor, not necessarily taking that big step back and looking at the whole picture, which is what you can gain from palliative care, having somebody look at the whole picture in addition to all the pieces of your care that are being put together. Sometimes people, if they have a skilled need and they're homebound, can have home care and have home care nurses, therapists, social workers, home health aides come and visit them in their home, and we can have the palliative team take over your home care if it's appropriate. That's one of the things that we determine, whether or not it's better for you to be just with the general care of the sick folks, where the goal is usually pretty short term and to get you off of the program, to get you better and off the program, versus if we know that you've got an illness that's going to be a little bit more protracted, that you're going to have ongoing needs, sometimes it's better for you to be with the palliative care team. And then the hospice program, of course, is one aspect of palliative care, but that we're going to talk about in just a minute, has some very specific criteria. You get the most home care services out of hospice. There's a little bit of a trade-off, and I'll talk about that in a second. And sometimes you may have contact with the palliative team through the hospital. We have, again, Dr. Anju Phillips, our Director of Palliative Care Services, sees people in the hospital, as well as an advanced practice registered nurse, Monica Kiltika. So you may have, at one time or another, talked to either or both of them if you've been hospitalized. So really, at every level of healthcare service that we offer, we also offer palliative care. So let's talk specifically about hospice now. Hospice is a home care program. It includes, home is anywhere where the patient lives, so that could be like, if it could be in your home that you've lived in for 40 years. It could be in a residential facility, like a nursing facility or an assisted living facility, as long as that's what you call your residence. You can't have hospice when you're on short-term rehab in a nursing facility, because they're really two different goals of care. And also, I always tell people, Medicare is a health care insurance, and Medicare kind of sets the rules for hospice care. Medicare is a health care insurance, and just like you wouldn't expect your health care to pay for your rent or your mortgage, then Medicare doesn't pay for your room and board if you're living in a nursing home. But it is a home care program. It is a benefit from Medicare. Medicare kind of is the gold standard, and then Medicaid and many commercial insurers also follow suit. But Medicare really makes the rules on hospice. So first of all, they have some very specific criteria. And the rules that Medicare sets to be for anybody who wants to get Medicare dollars for hospice care, they have to follow these rules called the conditions of participation. Just in case I use that phrase again, you'll know what I'm talking about. Medicare's conditions of participation include this criteria. You can have hospice if your doctor says, as of today, if your disease is allowed to follow its natural course, you could be gone in 6 months. Nobody has a crystal ball. A lot of illnesses are very hard to predict, so it's not like that 6 months is up and time's up and you have to get off the program. What will happen at the end of the 6 months is the hospice medical director or one of her APRNs will go out and do another physical assessment, and then every 2 months after that, they'll do another physical assessment. And as long as they still feel like you might be within a 6-month window, you can remain on the program. So you have to have that specific criteria of having an illness, a terminal illness, that could have a prognosis of 6 months or less, if it's allowed to take its natural course, and you need to be willing to forego any life-extending treatment. And basically what that amounts to are the trips back and forth to the emergency room, to the hospital, to the short-term rehab that so many people experience at the end of life. Hospice is an alternative where Medicare is basically making a deal with its beneficiaries. They're saying, we're going to give you more in terms of services, in terms of equipment in your home with no copay, in terms of medications that we keep. We keep a little emergency box of medications in the refrigerator, and they say, we'll give you this in exchange for you're not going to have a lot of futile treatment at the end of life, because that's really what studies show, are that when people get to the end of their disease process, where they're just like a revolving door in the emergency room or in the hospital or in the rehab, that they're getting less and less out of all of those trips. And a lot of people who have a serious illness say, enough, I'm done. And so if that's you, hospice might be right for you. And that's why if you wanted a consultation, we're glad to talk to you. There are times when people call me and they say, I want your program, and the doctor takes a look at the records, or maybe we send somebody out to do an examination of you, a physical in your home, and they say, you know what, you're not quite meeting criteria yet. That's good news, but at the same time, we'll tell them, when to call us back, what to report. We'll talk to your doctor so your doctor knows that this is your eventual goal to get onto the hospice program, and we'll keep an eye out for you. So basically, the goal of hospice care is really to empower the family and the patient to be able to stay home for as long as possible at the end of life, and hopefully all the way to the end of life. Most of our patients, I would say 99% at least, do die in the home because that's where they want to die. And if we have enough lead time to be able to get people home and get them comfortable and get them to meet everybody who's on the team and understand the services and understand that we're not there to take over your care, we're there to help you and your family learn how to do the care and keep you safe and comfortable, then we can be very successful in hospice. Sometimes people don't get onto hospice until very late in their illness. And at that point, I don't feel like they really get the full hospice experience. There's sometimes that people sign on to the hospice while they're still in the hospital because their symptoms warrant it, and we just can't get the symptoms under control in time to make that safe transition home. It does require a lot of work up front to get somebody home and safe and comfortable, but the more lead time we have, the smoother it goes for everybody involved. So what services does hospice offer? Well, first of all, we offer professional and volunteer support. So let me talk for a minute about the volunteer aspect of hospice. Hospice really started as a volunteer program back in the early 70s. It started here in the United States. It was already in existence over in Europe, but in the UK. But here in the United States, it started in the early 70s as a volunteer organization. Dame Cicely Saunders and Florence Wald from the Dame Cicely Saunders from the UK, and Florence Wald from Yale University, Yale School of Nursing, kind of got together, and they developed a team of trained volunteers who they trained up to be able to go into people's homes and support them to be able to stay home. And it really kind of took off so well that in 1982, Medicare said, you know what, we want to encourage this model of care at end of life so that people aren't getting futile care at the end of life, and so they developed those conditions of participation and kind of formalized it and started reimbursing organizations for providing hospice services. But the volunteer aspect, they recognize the importance of the volunteer aspect. So you get more services for less, Medicare does, because they have volunteer involvement. At the same time, I think this is one of those situations where it's good for the patients and the families as well, because they get more services that way. So Medicare actually dictates that we have at least 5% of the hands-on care that are given to our patients is provided by volunteers. And then in addition to the volunteers, we have nurses. We have a nurse case manager who's going to oversee your case. She's going to, you're going to be seen at least once a week, more often if your symptoms warrant it. Then we also have a nurse who works around the clock RN coverage, so that if something happens to you in the middle of the night, if you have a new symptom or something strange is happening, your family doesn't know what's going on, they can pick up the phone any time of the day or night and talk to the nurse on call, and she can either talk them through what they need to do to make you, the patient, feel more safe and comfortable, or she can come out and make a visit. So you can get a visit any time of the day or night. And that's what really keeps people out of the hospital. And sometimes when I tell people about this, especially if they have been in and out of the hospital a lot, they light up. They love this idea. And then we also have nurses who, also can go out on short notice if you're having changes during the day as well. We have therapists who work with us. The goal of therapy on hospice is not a restorative care plan of care, not to try to rehab you to a higher level of function than you were before. It's more to take a look at what your remaining strengths are and say, how can we make the most of these strengths? So that's what the therapists do. Occupational therapists, physical therapists, speech therapists. They work on giving you home exercise if you want that. They work on the safety of your environment, make recommendations on equipment if it's going to be helpful and keep you safer, and they'll do some training with your family. And then our speech therapists work with your family to modify your diet if it's going to make it easier for you to chew or swallow or anything like that, make recommendations on what you can be eating, and also they can work on speech and communication as well. We have pastoral care. Our pastoral care person reaches out to every one of our people within 5 days of coming onto the hospice program. And again, the reason for that, even if you have your own people, you go to your own church and everything like that, the spiritual counselor, first of all, can, take care of the communication there, notify your pastor or, your priest or imam or rabbi that you are in the hospital and get support for you that way. But it's also important to remember that other aspect of spirituality when you have a serious illness. People who are thinking about the end of life sometimes have that existential pain that the spiritual counselor can just sit and listen, talk to you, help you get your feelings out, and that's very important as well. We have home health aides that'll come in a couple of times a week and give you a good head-to-toe bath or get you in the shower if the occupational therapist thinks it's safe. And we have, I'm sorry. This is not advancing, is it? Okay. And then we have our volunteers, of course. And we have our volunteers do a whole variety of things in our program. We have volunteers that are specially trained. They're called doulas, end-of-life doulas, who have been in the caregiver role before, and so they understand what it's like to be the family member in this situation. So in a way, they're kind of a bridge between the patient and the professional staff, because we're all really good at what we do, if I can say so myself, but I think that sometimes we might forget what it's like to be brand new to this whole process, and the doulas kind of approach it from that aspect. They explain what's going on. You get this big fat booklet when you first come onto hospice, and they are well versed in going over that with you in case you have any questions and things like that. So that's our doula program. We have volunteers who work up on our general inpatient unit, the Comfort Care unit on South 7 at Middlesex Health, and that's for people who need a temporary hospitalization to get their symptoms out of control, with the goal being to try to get you back home again. So they, can get you, water and towels and, warm blanket and things like that. But they also spend a lot of time with the families, talking to the families, giving them support. Again, kind of serving that doula function of translating what's going on to people who are all new to this experience. We have volunteers who go out and visit people in the homes and provide companionship or respite for the caregivers who are taking care of people. And next week we're going to be talking about dementia here, and we're going to talk more about the importance of respite care on dementia. And we have volunteers who make bereavement calls, and in fact, we have a bereavement coordinator on the team who's a full-time professional. Our bereavement coordinator also happens to be a hospice chaplain, and her program extends for 13 months after the patient is gone. We will continue to be reaching out to the people left behind who are most important to that patient, to make sure that they're doing okay, to make sure that we're getting them hooked up with appropriate support or bereavement groups after you're gone. For some patients, hearing about the bereavement benefit is huge. And again, that's part of the Medicare conditions of participation. So even if you're not getting Middlesex Health Hospice, you will still get that bereavement benefit. Sometimes we see people going through treatment just to try to delay death because they haven't really thought through everything that's going to happen to the patient or their family that they're leaving behind. And so to hear about the bereavement benefit, that's very helpful. And then we have social workers who will help you not just with the emotional side of things or the psychological side of things, but also will help you to look at any financial things that need to be wrapped up, social programs that you might be able to take advantage of. For some people, there's a lot of business to be done at the end of life, and so social workers can take care of that. They can be prepared to help you through the functional decline because they know what comes next and what they should be helping the family get prepared for. Sometimes people live independently when they first sign on to hospice, but we know that every patient who's on hospice at some point is going to have a functional decline, and the social workers are there within the first 5 days of your being a patient being on service to help them kind of think this through. How's that going to happen? What's your safety net? Who's going to come in to supplement your care when you start to decline? And I talked about the comfort medications that we put in the refrigerator. Some families never even open up that box, but it's always there when we need it. Also, the durable medical equipment I might not have mentioned, but there's no charge to any of this. All of these services are covered under the Medicare hospice benefit. The hospital bed, the oxygen, you don't have to wait a month like you do with some of the home care programs to get approved. It's all taken care of right away, and so that's a big benefit for a lot of people as well. Okay, so the levels of care in hospice. In hospice, you're required to have 4 different levels of care. Anybody who's getting Medicare dollars for providing hospice care needs to be sure that we can provide these 4 different levels. The main one, again, is routine hospice care. In Connecticut, that's 97.6%. I think we probably are even higher than that in the number of people who are at home for us, versus any other, and that could include nursing homes, assisted livings. We do offer general inpatient care again on South 7, the Comfort Care Unit at Middlesex Hospital. So the criteria to be in the hospital to get hospice care, we're not licensed to be a residential hospice facility. We are licensed to be a hospital. So you need to be at a hospital level of care to be there. And those rules have changed over the years. So sometimes Middlesex has been in the hospice game since the 80s. And so for people whose association with Middlesex is much older or longer ago, this may have changed since you were on or another loved one was on the hospice program. Medicare is very strict about this, and we need to be showing Medicare every day that you really need to be at the hospital to get your symptoms under control, that we can't get you home again. And they don't want us, they want us to get your symptoms under control right away, so we need to be showing that you're making progress with that as well. So the stays on general inpatient tend to be very short, only a few days. And so I'm glad to answer any questions that people might have about that. Continuous home care, less than 0.3% of people in Connecticut get continuous home care. Continuous home care is just like the general inpatient care, except that it's in the home, you have a nurse coming and going. Some people think that continuous home care means like a private duty nurse, that the hospice is providing a private duty nurse. That's not what it is. It's really a nurse who's specifically coming in to get your symptoms under control and then get out again. So sometimes it can be a dissatisfier. If you only need to be there 8 hours and you get the person comfortable, then they say, what, you're not coming, you're leaving. So I just like to be very clear with people when they ask about continuous home care. And then we offer inpatient respite care as well. Again, that's offered on South 7, the Comfort Care Unit. Basically, your loved one will come in for 5 days to give you, the caregiver, a break. That's what inpatient respite care is. Medicare is pretty strict about wanting it to be brief and infrequent. That's what the conditions of participation read. They let us as an agency define brief or infrequent. So basically we say like once per certification period or once every 90 days for the first 180 days, that first 6-month period, you can have 2 respite periods in there. And then when the certification periods, those periods where the nurse or doctor has to come out to say, yep, she still qualifies for hospice care, you can have 1 respite stay every 60 days at that point going forward. Basically, it's just staying in the hospital, but you're on that one unit where the staff are specially trained to take care of hospice patients, to look for nonverbal pain cues if your loved one can't express themselves very well, to keep families up to date, really are in tune with that whole family-centered care. So we talked a little bit about the hospice people coming on the services too late. So I always like to show this slide to people. If you can imagine the y-axis there as people's level of function. And by level of function, to be really clear, I mean, can people get themselves dressed, get themselves washed up, brush their teeth, be able to go to the bathroom on their own, ambulate on their own, all those kind of things. When people have a serious illness, especially if they're hospice appropriate, we do see a decline in everyone's function. And so these are the trajectories that these illnesses usually take. So if you can imagine that bottom line, the x-axis, being time, or like the last 12 months of care, let's say, the last 12 months of life, then people who have cancer, which is the green line, they tend to remain at their baseline function while they're getting their treatment. Maybe they have a few setbacks because they're having some side effects or whatever, but basically they stay the same until the treatments stop working. And when the treatments stop working, we see a very precipitous decline in their function a lot of times. So a lot of times they want to continue to treat or take advantage of clinical trials and things like that, but if that's your goal of care, hospice is not for you. If, however, you've decided that you've had enough of the treatments, that you would rather spend the time that you ordinarily spend going for chemo, going for radiation, going for blood products, going to see the oncologist, if you decide that you've had enough of that, then hospice might be right for you, and you should give us a call. The blue line represents the disease trajectory for people with end-stage organ disease. So that would be like pulmonary disease, heart disease, liver disease, kidney disease. Those folks, because none of your organs operate all by themselves, a lot of times what their disease trajectory looks like is a gradual decline and then a dip, and then you come back but not quite to the same level, and then you decline a little more gradually and then another dip. So all of those dips in the blue line there, that is what is represented by trips to the hospital, trips to short-term rehab and things like that. Those dips get a little bit more erratic at the end, as you can see. And so when the visits to higher levels of care start to get closer together or harder to predict, that might be time for you to consider being on the hospice plan of care. And then the red line there, I want to point out to anybody who knows someone who has one of the diseases that causes dementia. The diseases that cause dementia a lot of times can be a very long illness, very protracted, and so they usually come to us in the last year of life or the last 6 months of life, very debilitated already. And what we see a lot of times with those folks is that their primary caregivers, whether it's a spouse or a child, or even a paid caregiver, whoever, they have gotten much more isolated. It's just them and the patient a lot of times, and they've lost their social ties, and they've can't go to church anymore, and they can't just drop everything to go out and run errands and things like that. And so we find that hospice is very beneficial to not just the patient, but their whole, their caregivers at that level of care. A lot of people don't realize that you can have hospice if you've got dementia. Again, we're going to talk about dementia in our last week here, and I hope that if you know somebody who can benefit from it, we'd love to talk to you about it, because it's kind of a hidden crisis in our society right now, and it shouldn't be, because there are so many people who have it and who could benefit from these services that never know that they're available to them. So, what is hospice really all about? Hospice is about living life to its fullest. Some people say, oh, I'm not ready for that yet. I'm a fighter. I don't want to give up. Hospice is not giving up. Hospice is saying yes to the things that were important to you before you got sick. And that's something that's really important for everybody to bear in mind, is time is your most valuable thing when you're terminally ill. And if you're ready to make the most of every minute, then you might want to think about doing hospice. I worked as a case manager for many years in palliative and hospice care. So some of the people that I had were my palliative patients who were receiving life-extending treatments, but knew at some point that their disease was going to be terminal. And they would ask me sometimes, well, how will I know? And I would say, well, you know what? On those days when you go to treatment, let's say that you have to go for a blood transfusion, once a week or something like that. When you wake up in the morning, ask yourself, how would I be spending my time differently? And sometimes you'll have an answer, or you'll, say, well, I could be doing this or this or this, but there will come a time when you say, you know what, I really want to do something else. I want to have lunch with my friends. I want to, visit my grandchildren. I want to go to the beach and sit and have my cup of coffee at the beach or something like that. When those kind of things become more important to you than going for treatment, even knowing that, you might not live as long, that's when hospice will be right for you. Some people think some people think of hospice being a place. Hospice is a philosophy of care. It's really about home. I keep talking about home, but it's true. Hospice is about being safe and comfortable at home. It's not about going to another building to live. There are residential hospices, and again, in Connecticut, not that many. People think of Connecticut Hospice in Branford, but even they have to follow. They were the first hospice in the United States, and they've had to change their rules for who can come in to stay there, just as everybody else had to change their rules as time went on. So you still have to meet certain criteria in order to live there, unless you're paying out of pocket the way you would at a nursing home, and you would have to negotiate that with, whether, if they have a bed for you and that kind of thing. There's another hospice in Danbury that has that same model where you pay out of pocket to live there, and then it's a hospice. I think those are the only two in the state of Connecticut. In other states, you see more of that, but I think Medicare seems to be trying to push everybody toward the home care model and getting it back to its roots. I just want to mention morphine because it always comes up in discussions of hospice, and a lot of people are afraid of morphine, and that's because morphine is a very old medication. It's been around since ancient times. People learned how to extract morphine from the opium poppies. And we've gotten very sophisticated about how we use it. When I was in nursing school, they used to make us memorize this statement that morphine has a morphine decreases respiratory effort. And it's true that it will do that if it's given in too high a concentration, too high a dosage. But we give it in a very judicious dosage, and we start low and go slow, and we find the right dosage for the patient that we're looking at, and we establish that dosage quickly, but in a way that is very controlled, because if it's taken in the right dosage, it can be a little sedating for the first couple of days of regular usage. That side effect will go away, unless, of course, the patient is declining, their underlying disease process is declining. So sometimes people don't take morphine until they're in their very last days of life, but it's because the reason that they die is not because of the morphine. It's not a cause and effect. It's that they were taking the morphine because they were dying, and they died because they were dying. So there are two things that are related to a third cause, and sometimes people don't really understand that, so they can be very afraid of morphine. We don't give morphine to hasten death. A hospice is not about prolonging life, but it's not about hastening the end of life either. So morphine is something that we've really gotten sophisticated about how to use it. We use it in conjunction with other drugs like lorazepam so that we don't have to use quite as much. And the staff will explain all of this to you when you're taking care of your loved one. Morphine does a lot of things. It's for pain. That's what most people think of. But it also relaxes the muscles in your rib cage, relaxes your diaphragm to decrease the work of breathing. And that can be hugely relieving to people who are at end of life, who are having that shortness of breath. And just remember that prognosis is a guideline. It doesn't mean that you're going to die at the end of 6 months if you elect hospice. You might have less time, you might have more time. We've had people who continue to meet criteria, when they enter that, excuse me, enter that phase where the hospice APRN or doctor has to go out and examine them every 2 months. We and say, yes, they might still only have 6 months left if the disease takes its natural course. For some people, they wind up staying on our service for a year, 2 years. If it goes on too long, Medicare starts to look at our records, so that's why we have to be really careful about how we document and show that there are measurable signs that your loved one is having a decline. If they kind of hit a plateau where they're not declining at all, we might graduate you from the hospice program, but we'll tell you and your doctor when to call us back in again. And it's definitely not just for imminent death. In fact, I really don't feel like you get the hospice experience if you're, waiting till the very end of life, hours to days to get it. Hospice is about patient empowerment, and so is palliative care. So one thing that you might want to think about when you come away from here is understand that not all healthcare professionals understand what palliative care is or what hospice care is. We talk to many doctors who we say we think that this person is hospice appropriate, and they'll say, oh no, he's not ready for that yet. Because in their mind, they're thinking about those people that sign on in the last days of life. They're not looking at the opportunity cost of not having you sign on earlier. So don't feel bad about, being assertive with your doctor and saying, you know what, I'd like to have a referral to hospice care. If they say that they're not sure that you're ready for that yet, say, you know what, I think I'd like to talk to the team anyway. But you actually don't even need to go through the hospice or through your doctor. Eventually, we have to get a referral from the doctor, but if you just want to know more or want to know when it's going to be right to call back, and likewise for palliative care, if you want to know if you qualify for palliative care, you can just give us a call directly. Just visit our website, our number is there. More than likely you're going to talk to me or one of the other people whom I work with. So just in summary, palliative care is for any age, any stage of illness, whether it's curable, chronic, or life-limiting. So it doesn't matter what your goals of care are. Hospice is specific to the hospice Medicare benefit, even if you're on Medicaid or a commercial insurance, and not every commercial insurance has a hospice policy, unfortunately, but when they do have a hospice policy, it generally follows the Medicare conditions of participation, more or less. They all have their little differences about whether or not you need authorization or not, that kind of thing. But in general, you're going to get the same experience that all the Medicare beneficiaries are getting. Timing for palliative care, there's no timing restrictions. If you have a serious illness that's affecting your quality of life, you can give us a call and we can see what we can do for you. Hospice, of course, has that time limit where the doctor says if the disease is allowed to run its natural course and you're ready to let the disease run its natural course, that 6 months is about what they think the doctor thinks you might have left, 6 months or less. But not necessarily either. And basically, the reason that we're getting out here and talking to you about these things is that we want you to know us before you need us. Payment is for palliative care. It's covered by most insurance, but sometimes you have to meet specific eligibility criteria. That's our job to look into that. You just make the phone call. We'll do the consultation. It lasts anywhere from 10 minutes to an hour, depending on how much you have to get off your chest, basically. But I'm fortunate to work for an organization that values that, and they let me have whatever time I need to talk to people so that we can, kind of think about your illness as how it's affecting you as a person. It's sad when people think I'm a cardiac patient, or I'm a kidney patient or something like that. You're not your illness. You're a much more complex person than that. And so sometimes healthcare really kind of just focuses on those smaller aspects, and we want to pull back and look at the big picture, try to address the specific aspects of it, but also look at the big picture and make sure that those things are matching. And the payment for hospice, for most people have Medicare, most of the people that we see have Medicare, so that it would be paid for by the Medicare hospice benefit. It is a benefit that you are entitled to if you have Medicare. So there are times when people will say, well, I asked, they'll be living in a nursing home, and they'll say, well, I asked the doctor if I can have hospice, and he said that he can do all the orders that you guys do. And that's entirely true. He can do all the orders that us guys do, but we can also do other things and bring more services to you than maybe that doctor is even aware of. And so, especially like in the nursing home, you get some individual attention from a home health aide. The aides can be wonderful in the place where you're living, but they also have an assignment of 7, 8, 9, 10 people maybe at a time. And so for an hour to have a home health aide come in and give you that individualized attention can be quite a luxury. That's all to say that Medicare, the Medicare hospice benefit is something that you're entitled to if you're of Medicare age. Medicaid, we would certainly look into it, make sure that you meet all the criteria for that as well. That in the state of Connecticut usually follows the Medicare guidelines pretty closely. The commercial insurers are a little bit different, but basically Middlesex is committed to, bringing these services to all of the people in the community. Palliative care, in terms of location, remember that you can have it in your physician's office, you can have it home care services in the hospital, the clinic, and then telephone consultations. Hospice is something that we really try to keep at home, including your assisted living facility or your skilled nursing facility or group home. We have people in group homes that we work with the group home staff. In palliative care, the treatment, it's to provide comfort, yes, but you can continue to have, continue with your life-extending treatments. So it's very helpful. A lot of the people that we have on palliative care are undergoing, cancer treatments or other treatments for their serious illness, can come back to the hospital anytime. The big difference, besides whether or not you come back to the hospital or go to rehab or anything like that, is also that we have a nurse on call 24 hours for the home care, but if you have something that's really serious, they're just going to say you have to call 911. They're not there to bring the emergency room to you. So that's another big difference between hospice home care and palliative home care. And then on hospice, the treatment is really concentrated on safety and comfort in the home. And it's for you and your family. So this quote, "Don't send me flowers when I'm dead. If you like me, send them when I'm alive." I think we decided to put this in just because a lot of people don't really realize that there's an opportunity cost to only focusing on your treatment and on your serious illness all the time. And we want people to be able to step back, whether you're on palliative care or hospice care. We're really trying to encourage people to step back and appreciate other people in their lives at whatever stage of their illness they might be, and make the most of their life. We have a couple of case studies. Do we have time? We're good? Okay. We have a couple of case studies to talk about. Here's one, a palliative one that I'll talk to you about. Pauline was 84 years old. She had a lot of different medical diagnoses, including diabetes. She had chronic kidney disease, stage 4, which is pretty advanced. She had congestive heart failure, COPD, chronic back pain with opioid use, and chronic constipation. She lived by herself in a 55-plus retirement village, and we saw her making numerous trips to the emergency department in the 6 months before we had our consultation with her. She had dehydration, hypoglycemia, exacerbation of the CHF, different reasons, all related to her underlying causes. So we did the palliative consultation with her. You wouldn't be able to see it if I clicked on it. The type is too small, but I'll just kind of cut to the chase and explain what happened. I talked to Pauline about what her goals were. She actually didn't mind going to the hospital. She actually kind of liked the attention, I think, and that was the impression of her children as well, that she was a former nurse, which I didn't put in here, but she really enjoyed being part of that hustle and bustle again and things like that. And so she was actually hospice appropriate. She met hospice criteria, but we didn't push her to get onto the hospice plan of care because that wasn't her goal of care. So we worked with her and her sons to figure out how we can continue to keep her safe and comfortable at home so that she can continue to receive all her treatments. She had a long list of medications, and some of those medications were kind of interacting with each other, so the palliative doctor looked at them and said, you know what, if we got rid of some of these and then maybe prescribed this medication for the itch, because she was having a lot of itchy skin all over itch that was driving her crazy, and it was because she had so many, her body was just trying to process all these meds. We had to keep talking to her about, because she would see the commercials on television and she'd be like, I want to try that one, I want to try that one. And so we had to kind of do a little bit of education with her, ongoing education with her, so that she wasn't really letting the television commercials, drive her health care so much, because she had a lot of doctors. And, if this doctor said no, she'd go to that doctor. And they were all specialists, and each specialist kind of looks at things in their own way. So we were looking at the big picture, talking to her about how to get all of her treatment into one system, because she was actually going to the Yukon system and the Hartford system and Middlesex system. They don't all talk to each other necessarily, although Hartford and Middlesex are now in Epic and we can see each other's records. I don't know about Yukon, to be honest with you, but it's a little easier when you're all under the same healthcare umbrella. And she was able to continue to do well without as many trips to the hospital. She was getting that gratification of having the nurse come out and talk to her every week. That kind of took away that desire to dial 911 and go to the hospital and things like that. And she had a much better quality of life, I think, once our team got involved. This is Harry. Harry is 82 years old with a history of dementia and progressive cognitive decline following a stroke 5 years ago. His wife reported multiple falls at home, and the wife and the patient lived alone in a house that he built 50 years ago. They had 2 grown children who lived in neighboring states. And several episodes of pneumonia in the past year. Harry had had several episodes of pneumonia in the past year with 3 hospitalizations. Then he'd go to rehab after that. And every time he left the home and went to a facility, he would come back at a lower baseline, which is very typical with people with dementia, which we'll talk about again next week if that's an interest of yours. But what happens is, sometimes because Harry his wife was such a steady caregiver and had their routine set up and everything like that, that really contributed to his doing well. And then by going to the hospital or going to the nursing home, that would take him out of that familiar routine, and he'd lose a little ground, and you never kind of get back to the baseline with it. He began to get more and more restless and difficult to manage, especially at night for his wife. He had had a number of falls because he was always trying to get up, even though he really couldn't get up anymore by himself safely. And the Care at Home team was seeing him, but they were the ones that made the referral to us to say, gee, do you think it's time yet for you to talk to his wife about this? He was no longer making any goals in his therapy, and that's another telltale sign, is if you're getting therapy and you're just not making any progress, you might be at your new baseline. So with Harry, I talked to his wife a number of times on the telephone, explained the program. She talked to the kids. We all had a Zoom meeting together. I'll say one thing for COVID, everybody knows how to Zoom in this day and age, and it's been a boon for us because sometimes you have family members all over the country, and this is a service that we offer you for free. If you feel like you want a palliative or hospice consultation for a loved one, we can have a family meeting. The patient can be present if they can participate. They should be present if they can participate. And everybody hears the same thing at the same time. They can have their conversation there with me, or if they want, I'll give them some guidance on what to talk about, and then they come back to me afterward and tell me what they decide. But that's what happened with Harry and his 2 kids and his wife, and they decided to elect the hospice benefit, and he was on the hospice benefit for several months, and in that time his wife was able to get a little respite herself. We had 2 volunteers involved in the care, so somebody could be with Harry sometimes, and then we had the volunteer doula who was giving the wife support and talking to her about her frustrations and what's normal, what's not normal. And sometimes just by being on hospice, like when people hear that you're on hospice, they're like, oh, I better go visit Harry or whatever. So, they got a little bit more support from their social circles because people found out that Harry was on hospice and they didn't realize that they had let so much time elapse. And so, and for a while, Harry could really take advantage, would talk to people, old friends about old times and things like that. But as is usually the case with people with dementia, Harry's world, continued to get smaller and smaller. He got more and more withdrawn, and a lot of the care shifted over to the wife who really needed his support. And then he died peacefully at home, and she had the support of the bereavement group afterward to help her get through the fact that her life has totally changed now. Even though Harry was a lot of work, he was her whole world. And so then she was, had the bereavement support to help her kind of think about how to move on from that as well. So this is the part where we ask questions, of course, because this is a do-over, or because we don't have anybody here to ask questions, but Alex or Pastor Doug, do you have any questions for me?
So there's no time limit for when someone can call you about palliative care?
For palliative care, there is no time limit. If you have a serious illness that's affecting your quality of life, you can pick up the phone and call our palliative care team at Middlesex Health. And, we'll talk you through that questionnaire, and then we'll tell you what our recommendations are. Do we always have ongoing services? Not necessarily, but sometimes that's all you need, is to have that one and done conversation. And then what I usually do is reach out to the doctor. I share, all your answers to your questions, the primary doctor, and let them know that, her goal is to finish treatment and, try to get off service, or her goal is to eventually accept hospice, whatever the person's goal might be. I'll communicate that to the doctor. Sometimes all it is a matter of, we've had a lot of situations where people have been struggling with a symptom, and because they have a lot of different specialists, the specialists all kind of think that it's the other specialist's job to fix that. And not in a, I don't mean to say that in a derogatory way or anything like that, but like that case that we talked about, Pauline, sometimes it's not, it's all the meds you're taking that are, maybe counteracting with each other. And so a couple of times we've just had the palliative doctor rather, look at the medications and say, well, these two things shouldn't be taken in conjunction with each other. I would suggest this, and voila, the symptom goes away. So the goal is to support the patient wherever the patient is, and do whatever the patient's goal of care is. Sometimes the solution is, it just takes an outside person who's looking at the big picture to figure out how to make things a little bit better.
One of the things that stuck out to me with this whole thing is that it still seems to give a lot of control to the patient, because I think a lot of times they feel like they're losing control.
I couldn't agree with you more. In fact, I think that part of this is giving the control back to the patient. I think the overwhelming feeling that I get when I'm listening to palliative consultations is that people are getting a lot of care, but they somehow feel like things are not being managed. And that's kind of where our healthcare system is, not our healthcare system, but in America, is that we've gotten a lot more sophisticated about the care that we can provide, but as things get more sophisticated, you also have people getting more and more specialized. And when you have these people who are very specialized, sometimes you lose sight of the big picture. So I really like to think of palliative care being the ability to look at that big picture again and say, you know what? These are all good things that are being done, but they just can't all be done together. And, let's start setting priorities, or let's see if the cardiologist can tweak something a little so that the nephrologist's, issues are not a problem. Or sometimes it's just letting the patient decide for themselves. We like, every agency out there likes to talk about patient-centered care and how they provide patient-centered care, but in my experience, a lot of times you hear doctors talking to patients and saying, well, you should do this and this and this, not saying what the alternatives are to that treatment, not saying, what would happen if you decided not to treat at all, let things go their natural course. And patients just kind of get used to listening to what the doctor says and doing what the doctor says, but there's always something else, like, and people have a right to ask that. And so, yes, palliative care is really about empowering people to speak up and say, you know what, I'm not sure if I agree with that. I'd like to another opinion. Thank you very much.
Well, thank you very much.
Thanks.